Yeah, can
That's fine. Okay. Yeah.
everyone that's watching from afar hear me?
Yes, I can hear you, but I think Carrie needs to mute her
While we're
microphone.
waiting, my daughter sends me a text message every morning because she listens to the same radio station. What is the best movie soundtrack? I've heard
Bronx Tale.
Bronx Tale?
Yeah.
Oh,
Bronx Tale.
Best
Without a doubt.
There's only one answer. And it's
A Bronx Tale. A Bronx Tale, hands down.
500 Days of Summer, but she's 25.
I'm gonna say, what's the Greatest Showman? That's got a really good soundtrack. If you're into like, that's more like now, but you can do back like older movies.
Bronx Tale.
Bronx Tale?
I have to look
Yeah.
that up.
Nice. Okay, we're gonna go ahead and get started. Dr. Morrison's gonna present this morning on local anesthetics and peripheral nerve block. This is gonna be recorded, so anybody else who wants to share it and view it later certainly will be able to. And I ask for your undivided attention.
Thank you so much. Hopefully everyone can hear me that's listening. If you can't, let me know if my slides aren't advancing.
They can stay in the chat too, if they want.
Okay.
I can
If my slides aren't advancing, let me know. If we haven't worked together, my name is Alex, one of the anesthesia residents. I'm going to talk to you guys about local anesthetics, peripheral nerve blocks. Feel free to interrupt me anytime. We can make it more of a casual, informal discussion. I don't want to feel like I'm just sitting up here lecturing, but if you have any questions, feel free to interrupt. And hopefully, I know I've gotten to work with you a lot, several of you, but sorry if I haven't met everyone that's on here. All right, so we're gonna get into some pharmacology, some case study or some cases, and some blocks and anything like that. If anything's unclear, just let me know. So I just put this up here first because I thought it was funny. Does anybody know what this plant is below? It's actually the coca plant. So the coca plant in South America is where we actually extracted the first local anesthetic from. It's where we get cocaine from. And so cocaine was the first local anesthetic that was synthesized and used back several years ago, I think in the 1800s initially. So that's where all the local anesthetics came from, derivatives of cocaine, and that is the coca plant where it's extracted from. Okay, so getting into some of this stuff. So types of local anesthetics, two different kinds. The two main local anesthetic classes that we have, one is the amides and the other are esters. Amides are typically the ones that we use most of the time. They're called amides because they have an amide bond. Their classic amide bond here compared to an ester bond here, and that's why they're called that. So the amides are the ones that we typically use. You'd recognize the names of bupivacaine, lidocaine, and ropivacaine. Usually those are what we like to use as anesthesiologists. Cocaine, procaine, tetracaine, chloroprocaine are examples of esters. We still use esters, not as often. And cocaine still used clinically. Chloroprocaine sometimes we use in spinals, but not so much anymore. And there's also mepivacaine and prilocaine that are amides. But most of the presentation will be focused around the amides, the bupivacaine, lidocaine, and ropivacaine, just because we use them the most. So just here's a clinical pearl. So you are the PACU nurse for a patient who had just had arthroscopic knee surgery. The surgeons wanted the APS team to perform a post-op adductor canal block for breakthrough pain. However, you notice upon review of the patient's allergies, they have a quote-unquote local anesthetic allergy. This was not mentioned to you in the PACU handover by either the surgical or anesthesia teams. An hour later, the patient's in excruciating pain. So can the patient still get a block with a reported local anesthetic allergy? So the answer is not super clear, but there are local anesthetic allergies. So true allergies are rare. Typically, this is very distinct from local anesthetic toxicity, which we'll talk about later. Most commonly, if there is a true local anesthetic allergy, it is due to the ester group of local anesthetics like cocaine, procaine, and benzocaine. The reason is because they share a structure to something called PABA, or para-aminobenzoic acid, which is a known allergen that patients have been reported to have. And the amides like lidocaine, bupivacaine, ropivacaine might have something called methylparaben in it, depending on who makes it. But it's vaguely similar to PABA, but the incidence of allergy is much more rare with amides. And typically, the way we tease this out is usually by history. So oftentimes they'll say, you know, they had a reaction to a local anesthetic, and oftentimes it's, at least the ones that I've encountered, where they went to the dentist, they got some sort of local anesthetic. Usually it contains epinephrine. And if the dentist isn't careful, they can give an intravenous injection accidentally, and epinephrine will get absorbed systemically. And they'll say, oh, I had tachycardia and I had cardiovascular symptoms. And so that's not actually local anesthetic allergy. It's because of the epinephrine that was in it. So asking the patient why, how, and all these questions about what happened when they got the local anesthetic is important. So the answer is that it depends. They most likely can get the block, but if their history is a true allergy based on ruling out all these other things, it really depends. So, but this is a rare occurrence. Most people do not have a true allergy, but it can happen. So anyway, how do local anesthetics work? So the mechanism of action, so just some basic physiology. Nerve impulse goes through the neuron and is transmitted along the axons by something called saltatory conduction. And these, in between the myelin sheath, there's these things called nodes around VA that are condensed, have a high concentration of sodium channels. Local anesthetics bind to those channels, and they prevent impulse action potentials from stimulating the cell and propagating along the axon. So the sodium channels, and you have no depolarization, you have no impulse.
What, for the Zoom?
Yeah.
Yeah, did you sign the thing?
No.
In the break room?
And so this is just a point I wanted to bring up, but there are people in this world that are resistant to local anesthetics. Oftentimes you won't find them here. It's a very small population in South Asia or India, where they found that some people have mutations of voltage-gated sodium channel. So that's why these people are able to walk on hot coals and not feel anything, because they actually have mutations of sodium channels. If you give them local anesthetic, it won't do anything. It's a special mutation that is very, very rare. I just thought that was interesting. Okay, so some structural and biochemical considerations for this. So the potency of the local anesthetic depends on its solubility in octanol, which is basically correlates to how easily it crosses membranes, because it can't get into the cell, it can't exert its effect. So the onset is dependent on the ionized fraction of physiologic pH. So these when we inject them into patients, these compounds are weak bases, and so meaning that blood is more acidic than the drug. So when you inject something that's basic into a more acidic environment, it'll become charged. It has a harder time crossing the membrane because it can't exert its action without getting into the cell. So that affects its pharmacokinetics and duration and onset of action, all of that. So, but the duration correlates with the potency, lipid solubility, and protein binding. So, for example, the main anesthetics, the local anesthetics we use, lidocaine, bupivacaine, ropivacaine, you can see that the onset for lidocaine is much faster because the pH of the solution, or the pKa, is closer to physiologic pH. It won't get as charged. So when we give lidocaine, it takes like a minute for it to work, versus bupivacaine, ropivacaine. We give it's a slow onset because it's a little bit more basic, so there's more charged particles floating around. So that's why we have to wait, several minutes for the block to set up, maybe even like an hour for a full anesthetic block. But the difference between lidocaine, bupivacaine, and ropivacaine, or lidocaine versus bupivacaine, ropivacaine, is really the duration of action. So lidocaine is super short, lasts about an hour-ish, sometimes less. Bupivacaine, ropivacaine lasts much longer, like 4, 6, 7 hours, maybe even 8 hours, depending. But this is why we use ropivacaine and bupivacaine for blocks, because they last so much longer. Lidocaine really won't do anything. And we use it for test dose and epidural, and it'll wear off. So duration is significantly different between the two. or the 3. Okay, so the rate of systemic absorption is related to the vascularity of the site. So this comes into play when we talk about local anesthetic toxicity. You really have to be careful. You can't just give a load of local anesthetic to somebody without thinking about some of this. So obviously, if you give it IV, you're gonna have 100% availability in the body. If you can give it tracheal, which is high systemic absorption. Also, intercostal is very high because the ribs are very vascularized, so it's easy for the local anesthetics to get absorbed. And then followed by paracervical, epidural, brachial plexus, sciatic, and subacute. If you use vasoconstrictors, you limit systemic absorption. So you have epinephrine within there, or within the local anesthetic solution. You limit the amount of vascular absorption because you vasoconstrict the vessels, preventing absorption that way. This isn't so much important, but one thing to note is that the lungs do extract local anesthetic. So you can have worse toxicity if you have a right to left shunt, or if you give an intraarterial administration on accident. Okay, so indications, when do we use these? We use them for a lot of different things. We use it for topical anesthesia. If we're gonna do like an inline or something, we'll just topicalize somebody right before we give it so that it doesn't hurt. Or I'm sorry, on a wake fiber optic, we topicalize mucous membrane, we do a local infiltration in skin, peripheral nerve blocks, which I'll talk about in a minute, mostly with bupivacaine and ropivacaine. And then we use it for IV regional anesthesia. Sometimes you'll see faculty that do beer blocks, not so much here when we give it intravenous. Epidural anesthesia, spinal anesthesia, 2-method liposuction. We use it all the time as an antiarrhythmic. And the thing to remember is that lidocaine or local anesthetics work on sodium channels, which are important in the brain and the heart. So it has just the similar effect in the heart, block sodium channels and affects induction with rhythm. And we use it as an adjunct to induction of anesthesia. Sometimes we prime before we induce anesthesia, we'll give lidocaine, and a lot of times it affects, blunts the effects of irritation of propofol. Okay, so when not to give it, if anybody has an allergy, hypersensitivity, Wolff-Parkinson-White syndrome, which is a arrhythmia where there's an accessory pathway in the heart, and if you give a sodium channel blocker in the setting of that, you can disturb the rhythm and potentially put somebody in VTAC or VFib. Severe heart block, obviously you don't want to give it because you'll potentiate the arrhythmia. And then interestingly, if somebody has a corn allergy, so apparently lidocaine may contain corn-derived dextrose, which you might not want to give if somebody has that. And then you can use it, you don't want to use it for a paracervical block in obstetrics. Beer block, you want to be really careful. Someone has cardiac history because you can, but bupivacaine especially is a higher cardiac toxicity than ropivacaine. You also do not want to give local anesthetic with epinephrine in anything that doesn't have collateral circulations like the digits or the ears or anything like that, so you can cause fibrosis of the skin.
No, I'm watching that.
Okay, so how do we dose these? So for bupivacaine, lidocaine, ropivacaine, really there's different concentrations,
The Zoom meeting
which is
today.
important in that you just have to make sure that
What's going on down there?
being cognizant of how much the patient's
But
getting.
I didn't know how to
So
sign
the
in.
maximum dosing for bupivacaine is about 3
Yeah, but it
milligrams per
doesn't say my
kilo.
name. It just says
We oftentimes round it to 2.5 milligrams per kilo because the math works out easier when we're at concentration of like 0.25%, 5% and 75%. For example, like
There's no
with
like
ropivacaine, if somebody is if the maximum dose is 2.5 milligrams per kilo, and the concentration of bupivacaine is 0.25%,
yeah, it just says
that's 2.5
though.
milligrams per ml. So
It
it's
doesn't
just
say
their weight.
me.
That's how we calculate it. So we usually round down because it just makes the math easier. If that makes sense. And then lidocaine, maximum dose is 4.5 milligrams per kilo. If you add epinephrine in it, the toxic dose goes up because you're limiting systemic absorption with epinephrine. And ropivacaine, it's at the same toxic dose.
Is there a way to minimize it?
2.5 to 3 milligrams per kilo.
Sure.
We give it for ventricular arrhythmias. The dosing's a little bit different. We can run lidocaine as usually.
Try to minimize it.
We also use it as an adjunct for induction anesthesia. We can give it with intubation and blocks the sympathetic response, adrenergic response to laryngoscopy and intubation. And we usually get about 1.5 milligrams per kilo. Okay, so talk about some nerve blocks. I chose these particular nerve blocks.
Let me see if I want to see if I see it where you.
Or that you might see in PACU, especially with the high volume of
67.
orthopedic surgery that we do, and these are the blocks that we typically do the most of on.
Let's go to.
Yes. So with the upper extremity, you have the interscalene, supraclavicular, infraclavicular, and axillary nerve blocks, and then the adductor canal or femoral nerve block and popliteal or saphenous nerve block. All right, so here's a case. 68-year-old male, the history of hypertension, arthritis, and BPH arrives in the PACU. Status post left shoulder arthroplasty. The case you were told was uncomplicated. You're also told the patient received a block pre-op. He received a paralytic during the case and was reversed to Sugamidex at the end. Otherwise, not much else in sign out. So the patient is ANO times 3 and hemodynamically stable. On your initial exam of the patient, you see.
No, I was. Did you know how?
Anybody have any idea what's going on?
I know. I was just when I first off, I was.
Yeah. So this patient having a stroke. Okay. How do you know? Yeah. So what's one easy way you could just rule out a stroke really quickly?
You don't get as much. The chance of winning is high, but you don't.
Yeah, or you just have them smile. So if we all think what we know is happening, this shouldn't affect the facial nerve. And if you're concerned it's left-sided, the facial nerve would be intact in this situation. You ask them to smile, show your teeth, or have them show you their teeth, and they shouldn't have any deficits there. If this is like what we're thinking it is from the block. So, but yeah, obviously you do full neuro exam, but if you have them to smile, the facial nerve would be intact, typically, which is not in a stroke if there is a left-sided stroke or left-sided facial group.
I've never been.
Good segue into interscaling block, and then we'll talk about what that was. So interscaling block indications, procedure involving the shoulder and upper arm. So usually this gives a really dense block of dermatomes from C5 to C7, which is illustrated in the picture here.
Yeah, they can't hear
So we'll typically are spared because when you inject the local anesthetic into the brachial plexus in the neck, the T1 nerve roots are actually in, so you're not actually bathing with your fullness in local anesthetic. So because of that, we don't use this block in anything distal to the elbow because that will not cover it because the T1 dermatomes are this, along this part of the arm. In the hand. When will we not do this? Anytime someone has an infection.
Inside the back like this.
And the reason for that is if the patient has an infection, you put if they have a systemic infection, if they're septic or something like that, you introduce a needle, or if there's an infection, say they have an abscess, shoulder surgery, and they want to block, well, no, because we're going to put a needle possibly through the pus, and then we can make the patient septic through that. Or if they're septic in general, you don't want to stick a needle if there's bacteria circulating anywhere either. And if they're coagulopathic, usually we check an INR, platelets, make sure there aren't any blood thinners, because I'll show you in a minute. There's a lot of important anatomy in there, and if you cause a hematoma, it's a potential emergency that would be very dangerous. One of the prime contraindications to doing this is patients saying they don't want it. If they don't want it, we're not going to force anybody to get it. It's it's our recommendation. It's actually standard of care for shoulder surgery now, depending on what it is. But if they refuse it, that's a contraindication. And if they have a true local anesthetic allergy, you want to give a bolus of anesthetic to them. Okay, so the interscaling block, what can happen? So one of the major complications of this block is that almost 100% of the time, if the block is done correctly, which they usually are now because we use ultrasound guides so we can see all the anatomy, is that you get an ipsilateral phrenic nerve block. So on the same side, you give the block almost 100% of the time, you'll get a phrenic nerve block. Phrenic nerve innervates the diaphragm. We have two phrenic nerves on each side. And the reason is the phrenic nerve is innervated by the nerve C345, which we'll cover when we do the interscaling block. So that always when we're up that high, it's going to get blocked. So that results in a hemidiaphragm paresis. So, which will result in hypoventilation and dyspnea, obviously all of which is reversible once the block wears off. But obviously, you know, we use our judgment if they have any sort of respiratory disease, COPD or risk of hypoventilation because that's exacerbated.
That's okay.
We've also had surgeons be like, well, we want to do both shoulders. Can you block both sides? And we're like, absolutely not. If we paralyze the phrenic nerve on both sides, big trouble. So we don't like to do that. Then, okay, so like the case that we just talked about, you get something that was a classic example of something called a Horner syndrome. Usually it's on the ipsilateral side, always it should be at least. If it's not, then that's even more alarming. So it's called an ipsilateral Horner syndrome, and the classic, go back to the picture. So you get ptosis, meiosis, and anhidrosis. And the reason for that is, so ptosis is the drooping of the lid, meiosis is constricting of the pupil, and anhidrosis is like you won't see any, like the sweat glands won't be working in that area. And the reason for that is the T1 sympathetic nerve root goes up in that area, which innervates the pupil and the eyelid, which is all sympathetic response, and that'll get blocked with an interscaling block. So this is a classic Horner syndrome that we see that is not super concerning, and that is obviously temporary. I know patients, if they look at themselves, they'll be like, oh my God, something's wrong. But it's actually an effect of a sign of a good block. And then also, because we're in that area, which I'll show you in a second, there's a lot of important anatomy, like I mentioned. We're close to the larynx, close to the neck. The recurrent laryngeal nerve travels through that area. So if you block that, patients can be forced on that. Patients can be, because there's two recurrent laryngeal nerves. If you block one of them, they can get hoarseness, just like they would if they nick it during a thyroid surgery. You can also get a pneumothorax because just thinking about functional anatomy, the apex of the lungs actually comes up above the clavicle. So if for some reason or another, the needle gets directed downward, you can cause a pneumothorax, and also a seizure. So the reason for a seizure would be, so this is the incidence of this is much lower now because we do this on our ultrasound, so we can see this. We see all the vessels, the veins and the arteries, but if you accidentally inject local anesthetic into an artery, it's almost an immediate seizure. So the two ways we avoid that. We use it on our ultrasound, so we're missing the vessels, and we always aspirate before we inject any local anesthetic to make sure that we're not going into a vessel. Okay, and then this is just so if somebody was getting hypoxic, someone is breathing very well, you would get a chest x-ray most likely, and this is what you would classically see. So if a interscaling block was done on the right side, the patient was hypoventilating, this is a classic hemidiaphragm where you see the ipsilateral phrenic nerve paralysis, where the diaphragm is paralyzed and raised on the right side or the same side as the block. And this is a temporary thing, but it's just, if you were to do a chest x-ray, then this is what you would see. And then this is just an example of the functional anatomy in that area with the scalene muscles. The subclavian vein is here, the internal jugular vein is here, the carotid artery is here, and then the brachial plexus comes out here. So, and the trachea is over here, lots of important nerves. So this is a very sensitive area, a lot of important anatomy, and which kind of makes sense why you would see this. Okay, so the next block I want to talk about is the supraclavicular block. This is also colloquially known as the spinal of the arm. So we do this for
That's what I'm
procedures
doing. I
at the
almost
distal
just
to the
responded and said,
um,
no, it doesn't work.
and when would we not want to do this, kind of similar to a interscaling block? If the patient has an infection, they neuropathy, through allergy or pressure refusal. So complications, one of the highest risks of this procedure is a pneumothorax.
Take your shoes off.
And the reason is because you're even closer now to the apex of the lung. And if you point the needle distal, you give this block, there's a high risk of pneumothorax. And you might not notice it right away if the patient has a short procedure, or hypoxic, short of breath,
It was story time at work.
chest pain. This could be, something that manifests in PACU that wasn't picked up initially. And about 50% will get an ipsilateral phrenic nerve block, not as high as a interscaling block because you're a little bit lower in the neck because you're right above the clavicle. You will can also get a Horner syndrome with this, not as much as you would an interscaling block. And then a recurrent laryngeal nerve palsy, similar to an interscaling block. And then one of the risks is also subclavian artery puncture because you're right there next to the clavicle. But again, doing this with ultrasound, these are never really done blind anymore. And that these are missed, this complication is very rare because we use ultrasound and also aspiration for injection.
Yeah, it's okay though.
Oh, I'm sorry.
No, you're fine.
Similar block is an infraclavicular.
Sorry, it's a board game.
Okay. Probably good enough.
That's what I
Good.
needed to figure out. But
Okay.
it's you. Yeah, keep going.
Okay.
Sorry.
No, that's okay. Maybe if someone was getting mad about this and didn't want to hear me anymore. Oh, okay. And then then there's a infraclavicular block. So like the name suggests, this is given below the clavicle. I think it's stuck. There we go. Okay, and we do this for similar to a supraclavicular block. You get a similar coverage for arm, elbow, forearm, and hand surgery. Not as common as a supraclavicular block. One of the we're just like really block in, and we want to put the block in. We didn't realize this patient also had a subclavian central line on the same side. But maybe you guys knew that before we did because you guys are great. So like, oh no, they have a subclavian central line there. So that's something where we would not want to put one, or they have a pacemaker on that side. Because one of the reasons is that we have to go through the pectoral muscles to block the nerve, and we would not want to puncture through the pacemaker. That would be bad. Hopefully we would know that before going in. Considerations to think about for this is that there's risk of vascular puncture like anything. Pneumothorax, less likely than supraclavicular, although not unheard of. And then it's usually more discomforting because you're actually going through a bigger muscle, the pectoral muscles. And an axillary block isn't done too much. But it is, I've seen it done here. The indications would be elbow, forearm, and hand surgery. Contraindications, big one is infection and infection risk going into the axillary region. That's a higher risk of infection, also neuropathy and a bleeding risk. So the risk of toxicity and hematoma is much higher in this area. So if somebody had an axillary nerve block, it would be something to watch the patient a little bit more carefully for, just because the axilla is highly vascularized with small veins, so making it very easy for local anesthetic to absorb systemically. Okay, so then we switch gears and go to the leg for lower extremity blocks. This is just an example of the different dermatomal covered patterns, which I'm not going to go into too much, but just to show you. So one of the things that you've probably seen a ton is the adductor canal and saphenous nerve blocks. And it's a lot of times you'll hear it called the adductor canal block. But we're not actually blocking the adductor canal. We're blocking the saphenous nerve that travels through the adductor canal. So we just call it that. So the actual nerve that's being blocked is the distal end of the femoral nerve. And then once it passes the knee, it's called the saphenous nerve. So the indications for this would be saphenous vein stripping or harvesting. Knee surgery, oftentimes we'll do it for arthroscopy, patella, ACL or MCL surgeries, and then foot and ankle surgery in combination with a sciatic block, which I'll talk about next. And then this, when it's in combination, it gives you a complete block to the lower leg. So the adductor canal is right about here. It's in the distal thigh on the medial side, and where the femoral nerve runs through. And then once the femoral nerve crosses the knee, it becomes a saphenous nerve. And so when we block it right up here, it gives you medial and anterior numbness to the leg. So you can see why that you can't just do ankle surgery with just a adductor canal block. You need the other side as well, because you don't get the posterior or lateral side of the leg. So contraindications, again, refusal, bleeding risk or infection are reasons why we wouldn't want to do this. And then complications. So with an adductor canal, I've seen in the literature and some of the textbooks, they say that neuropathy is seen in about 6% of patients. And this is something that you guys might pick up on in PACU, saying that they come out of the OR. A lot of times these are done before we go back. And they said that they have electric shock sensation in their leg, and which is different than pain. This is more of a neuropathic pain. It's not surgical pain, but it's electric shock sensation. And this is temporary. Usually they recover within 3 weeks. If they don't, then we refer them to neurology for nerve studies and things like that. And then one of the risks or complications is also vascular puncture and development of hematoma, et cetera. Okay, then the next block for the lower extremity is the popliteal. So like oftentimes you'll hear us talk about like POP-SAPH blocks. Which is the saphenous nerve block I talked about, that we'll talk about the popliteal. There's not actually a popliteal nerve. We just say a popliteal block because that's the space that we go into to block the nerve. And the nerve that's actually being blocked is the saphenous nerve. And so the sciatic nerve. The sciatic nerve comes down the leg, and then right at the popliteal fossa, which is just behind the leg right here, the nerve splits into the common peroneal and the fibular nerve, or the common fibular and the deep peroneal nerve. And so we block it in this area right about here, just superficial to where they branch off, so you get the posterior and the lateral side. But like I said, we only call it a popliteal block because that's the area where that usually splits just superior to that. So this is done for foot and ankle and Achilles tendon surgery, usually in combination with a saphenous nerve block I just talked to you about. And when we do those two together, you get complete anesthesia to the lower leg. Again, we don't do this if they refuse it or if there's an infection or a bleeding risk. And then complications, again, just like most of these, are bleeding and infection. In the popliteal fossa, there are major vessels, the popliteal artery, popliteal vein that we have to watch out for. But usually, most of these are avoided with ultrasound. Okay, and then there's two more things I want to talk about. One is local anesthetic toxicity, and I have a case at the end we can discuss. So local systemic toxicity is a real thing. So you see this primarily present in organs that require sodium channels for proper function. So like we talked about, the heart and the brain have voltage gated sodium channels that rely on action potentials in the sodium channel that are blocked by local anesthetics. So this is where typically you see the effects. And like I mentioned, something to bear in mind is the maximum dose of local anesthetics with bupivacaine, ropivacaine, and lidocaine. Again, is 2.5 to 3 milligrams per kilo for bupivacaine and ropivacaine, and lidocaine is 4.5 milligrams per kilo. And oftentimes what happens is we'll give these patients blocks in pre-op, and then we'll go to the OR, and the OR surgeons will ask us, like, how much extra local anesthetic can we give? And so we calculate the toxic dose for these patients to make sure that, you know, they give local in their skin incisions or whatever. And we've also given a boatload of block, or they've gotten a spinal as well. So we make sure that however much they're giving, we don't let them give anything else until they've checked with us in the operating room to make sure that they're under the maximum dose, so they don't come out to PACU and have systemic toxicity. But it's a good thing. I think it's good for you guys to be aware of some of the signs of it in case there is, because like I said, depending on where they inject this, there's really high systemic absorption. If they give it intravenous accidentally, I mean, they could be giving, like, oh, we're giving it sub-Q, but they actually give it intravenous. We don't really necessarily aren't watching them inject it. Tracheal, intercostal, areas of high vascular area will be highly systemically absorbed. So neurologically, what would you see? So the early symptoms of this, classically, you would see circumoral numbness. Sometimes this could be, you know, confused by, like, maybe their calcium's low or something like that, where they have like numbness, tingling, or tetany in the area. And, you know, one good thing to know would be, like, if they got a bunch of local anesthetic. A lot of times tongue paresthesias will have dizziness, tinnitus, vision, or, you know, this is kind of like a conglomerate of symptoms that they might have suggesting toxicity. And the big one is muscle twitching. So if you are concerned with a patient having muscle twitching, you know, they got a boatload of anesthetic, that is like almost always is going to herald a seizure. So if you see that, that's like a kind of a bad sign that something bad is going to happen, a potential emergency for a tonic-clonic seizure. So if you see muscle twitching have a really low threshold to call one of us. And then restlessness, agitation, nervousness, feeling of impending doom, those kind of all come with it. But the muscle twitching one is big. So if you see that, that's usually like saying, like, this patient might have a seizure pretty soon. Respiratory wise, if you get a boatload of lidocaine, it can suppress hypoxic drive. And then also, obviously, if they get like a ton of local anesthetic, their phrenic nerve is blocked, they might have apnea, or phrenic, the intercostal nerve paralysis. Cardiovascular wise, if they have systemic high doses of local anesthetic, they're going to have depression of myocardial contractility and conduction velocity, because the heart also has sodium channel, voltage gated sodium channels. Every single one of them except cocaine will cause vasodilation. Somehow the structure of cocaine causes an adrenergic state where they're actually vasoconstricting, and causes hypertension instead of the others that cause the reverse. And then, you know, the other thing to think about is, like, well, maybe if the patient has a cocaine intoxication before they go back and we get local anesthetics as well on top of that, you could potentially potentiate local anesthetic toxicity if they are, if there's an emergency and they have cocaine in their system, et cetera. So the cardiovascular toxicity actually requires 3 times of that, which precipitates a seizure. So it's much lower threshold to get a seizure than it is to have an arrhythmia from local anesthetic toxicity. Yeah, all right. And then, so what do we do when this happens? So the biggest thing is a pretty significant emergency, especially if they're having a seizure. And then if they have an arrhythmia, it could develop into VTAC arrest and VFib, et cetera. So obviously call for help, and the supportive measures are important, and ACLS and all of that. Life support, there are reports of, like, if people have refractory to antiarrhythmic medications, actually the primary antiarrhythmic that we would want to give is amiodarone. We would not want to give lidocaine in this instance, obviously, for VTAC arrest or just VTAC with a pulse. And if they do have a seizure, the recommended anti-epileptic is midazolam, about 2 milligrams to stop the seizure. And then once we get, their vitals and cardiovascular state a little bit better, at the same time, we're simultaneously getting the lipid emulsion ready. The lipid emulsion, it was like a serendipitous finding that they found can sequester local anesthetics and reverse the process. So we give in the block carts, I think in the bottom drawer, we have lipid emulsion that we would give in an emergency to reverse the effects of local anesthetics. Give a bolus of 1.5 mLs per kilo over a minute. Then we infuse at 0.25 mLs per kilo per minute, and then reassess, and they probably at that point need to go to ICU if they're unstable, and then we continue the infusion if the effects are still going on for over 10 minutes, and they need to be heavily monitored. So it's not a, this could go downhill real quick if not noticed right away. And then, okay, so another case. So you're just told about a patient coming to PACU from MPU. The 82-year-old female, the history of COPD who underwent a bronchoscopy. She was topicalized with benzocaine spray and is still a bit sleepy. The patient is on 4 liters of nasal cannula oxygen. So their vitals on arrival to PACU are the following: heart rate of 90, blood pressure 97/62, respiratory rate of 18, and SpO2 85%. You place an O2 face mask and the SpO2 does not improve. So the primary service came by and asked you to get labs. So upon drawing the labs, it looks like the blood is chocolate colored in the vials, and you're like, what is going on? The patient is somewhat of a gray bluish tint to their skin, but it doesn't look like they're blue like they would be hypoxic, but is responding appropriately in their AO times 3.
Michaela?
So you notify one of us, one of the PACU residents, and one of us asks for an ABG. The ABG results are the following. So the
Do you want
pH is
something to eat or
7.28,
drink?
PO2 is 150, the PaCO2 is 42, and the
Ice chips?
bicarb
Yeah,
is
I got ice
19.
chips.
Got a lactate of 2.5, and his SaO2 is 85%.
Okay, so done.
So
Okay.
chocolate colored blood, hypoxia, what is going on with this person? What is happening? Nice. Nice. Love it. So methemoglobinemia this is a really weird effect of local anesthetics. Typically, so you can have congenital methemoglobinemia, but you can also get acquired, and what we would see here is probably an acquired. So this is rare. I only threw this in there because it ties into local anesthetics. Classically, it's seen with benzocaine. Benzocaine isn't used anymore for this reason up in the MPU or endoscopy suites anymore because of this reason, although it is rare. But it's also, I think you can get benzocaine over the counter too. So, but and anti-malarial agents can cause this, and dapsone. And the reason is that all 3 of these types of drugs are very toxic oxidant molecules. And so the pathophysiology of methemoglobinemia is that it causes oxidation of iron in hemoglobin. And when that happens, oxygen actually can't bind to hemoglobin. And for some reason, methemoglobin actually will look like this. When you draw the blood, it'll look chocolate colored. For some reason, the wavelength on the pulse oximeter only reads a reading of usually 85%. And that's corroborated with an SaO2 of 85% as well on the blood gas. So when your sats are about 85%, you don't know what's going on. Something odd to think about that you don't see a whole lot. And the treatment for this is actually methylene blue. And so some patients can't get methylene blue for one reason or another due to complicated medical history or whatever. So we give a ascorbic acid or just vitamin C for this because these are antioxidants. And the antioxidants will reverse the effects of the oxygen molecules that are changing the chemistry of iron in hemoglobin so that you can then start binding oxygen to hemoglobin. And so after methylene blue is given, it really is just supportive care. But I've never seen this. It's rare. It always, at least for us, it always comes up on our tests, especially in the anesthesia world where topical local anesthetics are given. It's always something to think about. But classically, it's with benzocaine. Like I said, usually we use L-lidocaine if we give somebody an AFOI or a bronch or something like that. So it's one thing to be aware of. Yeah. Interesting. Okay. Yeah. Was it
And some water
nitroprusside
to
or
drink,
nitroglycerin?
Michaela.
Nitroglycerin. Okay. Yeah, interesting.
Okay.
So you've seen it. And does the
sleepy.
blood actually look chocolate? It does. Okay. All right. Because I haven't seen it.
I've been around a while.
Nice. Yeah. So this is like one of those weird things you see like are in textbooks, but I have never actually seen chocolate colored blood. But that's pretty cool. You've seen it. Okay, so
This
that's all I have. Thanks for
oh.
listening.
Oh, it's done.
Questions, comments?
Methemoglobinemia. Like the O2 can't go bind to the
Fun
tissue.
photo.
So you,
That's my only fun.
Family.
That's
where
my.
the blood's like really
So that is
chocolate,
from
he
a
said.
Buddhist monastery, the highest Buddhist
It
monastery.
starts by, he said, like Dapsone on
Looking
anti-malarial
at Mount
medication and
Yeah.
benzocaine.
Yeah.
Treatment is actually methylene blue.
So I went to Mount Everest base camp.
Wow, never heard of that, right? He's done. I was just trying to see what, because I
No,
missed
but
it.
oddly, I was at base camp at the same
Right.
time as Rock
Yeah.
Patel.
Now it's
He summited
questions.
it. I wasn't trying to die. So
It was nice, because he added more stuff.
that's my only fun.
Yeah,
Sure.
it was good. Yeah.
Yeah.
I didn't know this.
Okay, you're
Yes,
And
they've been
then
great.
he showed like the lipid emotion, how we give it as a bowl.
Thank you.
For toxicity? Yeah, for toxicity.
Alrighty, if you want to share your presentation, I can email it out.
Patricia.
Oh, sure. Sure.
Thanks, guys, for.
We can't